Hi everyone, my name is Holly Swilo, and today I'll be talking about mental health needs in special populations within primary care. As future FMPs, we don't just treat diagnoses, we treat people in specific life stages and social contexts. In this presentation, I'll be including 5 special populations, focusing on prevalence, screening tools, and treatment strategies we can use in primary care. The first population we'll be covering today is the elderly and geriatric population. About 14% of adults over 70 experience a mental health condition. Depression, anxiety, and dementia are the most common. Dementia alone affects roughly 6 to 10% of adults over 65. In older adults, mental illness often shows up differently. Symptoms may look like fatigue, poor appetite, memory issues, or withdrawal, and it's easy to connect those symptoms to the aging process itself. When left untreated, mental health illness in this group leads to more hospitalizations, medication, complications, caregiver stress, and overall decline in function. When assessing the elderly population, we have several great screening tools. The Geriatric Depression Scale works well as a screening tool because it avoids a strong focus on physical symptoms. The PHQ-9 and the GAD-7 are also useful, and cognitive tools like the MiniCog help us rule out any neurocognitive disorders. The DSM-5-TR reminds us to always rule out delirium, medication effects, thyroid issues, or vitamin deficiencies before diagnosing depression. In primary care, this really means slowing down and looking at the full picture. As with any treatment and population, we should always start with non-pharmacologic as appropriate. And some of those strategies include cognitive behavioral therapy, or CBT, physical activity, social interaction, and music or art therapy. If medications are necessary and appropriate, SSRIs like sertraline or escitalopram are first line, and we use a start low and go slow medication titration schedule with this population. Knowing what to prescribe is helpful, as well as knowing what not to prescribe, and we want to avoid benzodiazepines and anticholinergics because of the fall in cognitive risks in the elderly population. Just as important as the treatments that we prescribe, we also need to involve caregivers and coordinate with the interdisciplinary team. That support system often determines how well our treatment plan works. Our next population are the pregnant and lactating patients. Perinatal depression affects about 10 to 20% of patients. Anxiety is also very common during pregnancy and postpartum. Untreated mental illness in this population increases risk for preterm birth, low birth weight, and bonding challenges. So this isn't just emotional, it impacts both the maternal and infant health outcomes. When assessing the perinatal patient population, the Edinburgh Postnatal Depression Scale is preferred because it doesn't overemphasize physical symptoms that overlap with pregnancy. The PHQ-9 and GAD-7 are also appropriate for assessing depression and anxiety. The DSM-5-TR allows the peripartum onset specifier for mood disorders, and ideally we screen each trimester and then again postpartum. Regarding treatment for the perinatal population, mild symptoms, therapy is first line, especially CBT or interpersonal therapy. And so when medication is needed, sertraline is generally considered safe and is commonly used. With that being said, we avoid paroxetine in pregnancy due to the potential risk. The key strategy here is the shared decision making. Untreated depression often carries more risk than properly managed medication during pregnancy and after. As always, close collaboration between OB and mental health providers makes a huge difference. We will now be looking at the pediatric and adolescent population. 1 in 5 children has a mental health condition. Anxiety, ADHD, and depression are the most common. And suicide is now the second leading cause of death in children ages 10 to 14, which is staggering. Early identification in primary care is crucial in planning treatment for these patients and changing the outcomes. For assessment in the pediatric population, we use tools like the PSC-17, the PHQ-A for adolescents, GAD-7, and Vanderbilt scales for ADHD. The DSM-5-TR emphasizes developmental context, so what's normal at one age isn't necessarily normal at another. Assessment should include caregivers and sometimes teachers, but we also need to provide adolescents space to speak privately. For pediatric and adolescent patients, behavioral therapy is often first line. That being said, fluoxetine is FDA approved for pediatric depression and has strong evidence to support its efficacy. We monitor closely for suicidal ideation throughout treatment, but especially in the early stages. And family-centered care is key. If the home environment doesn't support the plan, outcomes can suffer. So collaboration with schools also can help reinforce our treatment plans. LGBTQ+ individuals experience significantly higher rates of depression, anxiety, and suicide. They can experience minority stress, meaning chronic stress from stigma or discrimination, and this contributes heavily to mental health conditions in this population. They often have healthcare avoidance, and it's common due to prior negative experiences in the healthcare setting. When assessing patients in the LGBTQ+ population, standard tools like PHQ-9 and GAD-7 work very well, but assessment must be affirming and trauma-informed. This is very important. The DSM-5-TR includes criteria for gender dysphoria, which requires distress and not just simply identity. Throughout treatment of these individuals, we should also screen very carefully for substance use and suicidality. Treatment plans for mood and anxiety disorders in the LGBTQ+ population follow standard pharmacologic guidelines. What changes is the environment. Care must be affirming, respectful, and inclusive. Referrals to culturally competent providers improve engagement and give good outcomes for those in this population. The next population we'll be covering are immigrants and migrant workers. This population faces migration trauma, acculturation stress, unsafe work conditions, and fear related to immigration status. Rates of depression and PTSD are high, but are often underdiagnosed, and barriers like language and cost limit access to care. When assessing migrant workers in the immigrant population, translated versions of the PHQ-9 and GAD-7 are very helpful. The Harvard Trauma Questionnaire can identify trauma exposure as well. The DSM-5-TR's cultural formulation interview improves diagnostic accuracy, and professional interpreters are vital. Family members should not be used in this case for the most accurate translation and information. When treating patients in this population, treatment should be culturally responsive and trauma-informed. Low-cost medications and community resources often improve adherence to treatment plans. Integrating behavioral health with primary care can be especially helpful in underserved populations. So, to wrap up the presentation, mental health care isn't one size fits all. Each population has unique risks, barriers, and considerations. As primary care providers, we're often the first point of contact. That gives us a powerful opportunity to screen early, treat appropriately, and collaborate effectively. By personalizing our approach to the patient in front of us, considering their age, culture, identity, and life stage, we can reduce disparities and improve outcomes for all patients that we treat. Thank you.